Okay, I already said it that in the glaucoma we're gonna use the epinephrine and the dipivefrin. So what are the action of these things? It's gonna do two things. So it's gonna act on the alpha 1 and alpha 2 receptors, and after acting on alpha 1 and alpha 2 receptors, it's gonna cause the vasoconstriction and decreases the ciliary epithelial secretion. And what are the two things? It causes alpha 1 alpha 2 constriction. Because of this there is going to be vasoconstriction and reduce the secretion, and because of this there is going to be reduction of the intraocular pressure. Along with this, it will increase the US scleral outflow, tubercular outflow, and reduces the intraocular pressure. Two things: alpha 1 alpha 2 contraction, and by acting on beta receptors increases the UV scleral and tubercular outflow. Okay. Now we have the myasthenia gravis. It can also come in the paper as well. We already studied the myasthenia gravis in first year MBBS, that the antibodies are formed against the acetylcholine receptors, and because of this, the acetylcholine the acetylcholine won't act on the receptors because the availability of receptors is really low. So for finding out the myasthenia gravis, we do three things. We are going to look at the sign and symptoms. We're gonna give the person hydrophonium, which is gonna help in differentiating between the myasthenia crisis and the cholinergic crisis. Along with this, we're gonna check the circulating antibodies. What we're gonna do, we're gonna check the sign and symptoms first. We're gonna look at we're gonna give the person hydrophonium, which is going to separate the myasthenia crisis from the cholinergic crisis, as well as we are gonna look the person's antibodies, which are binded with the NM receptors. Okay, for treatment of the myasthenia gravis, it can also come in the paper as well, so just look at like that. Okay, for the treatment of the myasthenia gravis, we give anticholinestrase, we give glucocorticoid, and glucocorticoid we give prednisolone, we give immunosuppressors, which are azathioprine and cyclosporin. We're gonna remove the thymus, so the antibodies cannot be formed, and we're gonna exchange the person's plasma, because the plasma contain the overstimulated antibodies, which we don't want. That's it. Okay, now we're gonna come on the irreversible anticholinesterase. And in irreversible anticholinesterase, we already said the drugs, which are the serine, soman, deflos, ecothiophat, parathione, malathione. Okay, now the in paper the sign and symptoms can come like, what are the sign and symptoms of irreversible anticholinesterase. So the sign and symptoms are muscarinic action, nicotinic action, and central action, and which we already know this. Like, just remember the position of the receptors and do take the functions out of it. Okay, now if the person have the organophosphorus poisoning, so we're gonna first of all we're gonna do the diagnosis. For diagnosis, what we're gonna do, we're gonna check the exposure of a person to organophosphorus compound. We are exposure, then we're gonna look at the sign and symptoms, and after that we're gonna check the level activity of the cholinesterase. Okay, what we do for diagnosis, we are gonna look at the signs and symptoms, we're gonna check the exposure of the person, and we're gonna look at the activity of the cholinesterase. Okay, for the treatment we use general measures as well as the specific measures. In general measures, we're gonna remove the person from that poisoning. And wash the person by soap and water. After that, we're gonna do the gastric lavage and remove all the gastric contents. Then we are going to maintain the person airway. Artificial respiration is given if necessary, and we are going to give diazepam for treatment of the convulsion. Okay, For specific measures, we're going to give person atropine, or we're going to give oxymine. What's the method of the atropine? In first dose, we're going to give 2 mg of atropine and IV stat. Then after every 5 to 10 minutes, we are going to give person atropine, but we are going to doubling the dose. For example, in first dose, the dose was 2 mg. So in second dose, after 5 to 10 minutes, the dose will be 4 mg. And then 8, and then 16, and then the process will go on until the poisoning is not finished, or until the person is fully atropinized. Okay. The atropine can be continued for 7 to 10 days. Okay. Now oxime is also given if the atropine is not working, so we're gonna give the oxime. So oxime, the examples are pralidoxime, and obidoxime. So pralidoxime and obidoxime, the doses are 1 to 2 grams. Okay. So we already said that the organophosphorus compound is going to be binded with the steric site. Okay. So what's gonna what's gonna happen? The oxime is going to be binding with the anionic site. It will cause dephosphorylation of the enzyme. Okay. And removing that enzyme from the organophosphorus compound. And that's how that's how the person is going to be recovered from the organophosphorus poisoning. But there is only one disadvantage of oxime, that we should give oxime very as early as possible. We should give oxime as early as possible, because if we late, so what's gonna happen, that the enzyme, which is the cholinesterase, is going to be the aging gonna happen, then because of the loss of the alkyl group. And when the loss of the alkyl group will happen, so then you won't be able to dephosphorylate the enzyme. That's it. The thing that can come in MCQs is that the prolonged exposure of the organophosphorus compound can makes the person neurotoxic. That's it. Thank you.